Testing 1 2 1 2. Check check 1 2 1 2. Testing 1 2. Check check 1 2 1 2. Testing 1 2.
Morning, everyone. Welcome to Grand Rounds. Let me mention that next week is a clinical Grand Rounds, so it'll be not streamed and not open to the public. I don't have any announcements today other than to say a Grand Rounds speaker is one of our own faculty, none other than Meg Haney. And Meg, I thought that I've heard her more recently, but couldn't have been because she said she hasn't given Grand Rounds since the year 2000, which antedated my arrival at Columbia. So this is her debut, at least in the Lieberman era. Well, Meg comes from New York. She went to Rutgers for her undergraduate school and then received her master's and PhD in experimental psychology at Tufts. She then traveled to France, where she did a postdoctoral fellowship at the Institute of National de la Santé de Research. And she then returned to Columbia, where she was offered a faculty position and climbed the ranks from assistant to professor of neurobiology and psychiatry. She also has assumed roles within the Division of Substance Abuse, which, of course, was founded and developed by none other than the late Herb Kleber. And in that context, she began a cannabis research laboratory, which was, in view of what's happening now, prescient. She became the associate director of the Marion Fishman Cocaine Research Laboratory, and also serves as a co-director of the NIDA-funded Substance Abuse Research Center. Meg has been a truly prolific and productive researcher in substance use disorders. Initially, her first paper was on opiates, but then after that, she really focused on stimulants with respect to specifically cocaine. But as cannabis became more interesting, maybe more prevalent, she also sort of diverged to include that as an area of focus, and now it's become sort of a predominant focus of her research. In the course of doing so, she's been pretty consistently funded by the NIH from largely NIDA. Just to give you an idea of some of her sponsored research, she has an R01 from NIDA on non-metabolized pregnenolone derivatives as a new treatment for cannabis use disorder, the effect of oral cannabinoids on toxane-induced peripheral neuropathy, cannabis influence on cannabis relapse, influence of tobacco cessation, and neurobehavioral mechanism of choices to smoke cannabis and cannabis use disorder. She has abundant publications in these areas and good journals, and obviously now, even though it wasn't necessarily what led her to this, she's really at the epicenter of an area of great interest and importance public health-wise in the country, which is this kind of tsunami of interest in cannabis and cannabis derivatives for all manner of uses, recreational and medicinal. So to say that this is a timely and important topic is an understatement. I'm so glad that we've scheduled this and look forward to hearing what she has to say. So please welcome Dr. Meg Haney.
Thank you, Dr. Lieberman. It's really great to be here. It's my silver anniversary at PI. I came here in 1994, so this feels like a good time to be up here. I have no conflicts of interest. My research has been supported by NIDA and more recently by the Thompson Family Foundation Initiative. So what I'd like to do today is talk about, I'm just going to first give some definitions of cannabis and cannabinoids, talk about the public policy and the regulatory barriers you face as a cannabis scientist, which are enormous. In terms of learning objectives, I'm really going to focus on the yin and the yang. I'm going to talk a lot about cannabis use disorder, which is really has been the primary focus of my research, and our attempt to develop pharmacotherapies for cannabis use disorder. But I also want to talk about the potential therapeutic use and the knowledge gaps and issues and the evidence that exists so far. But I'd really like to ask all of you to really think of how cannabis and cannabinoids influence your area of expertise. And, I'm happy to talk to anybody afterwards after you've had a chance to hear this presentation, because I really think that this topic has relevance across the range of expertise at PI, really from molecular neurobiology to epidemiology across the board. So I'm hoping that there's going to be something for everybody here. So in terms of the yin and the yang, is cannabis good or bad? It's clearly both. This is a pharmacologically complex plant with constituents that have the potential for producing both medical benefit and abuse liability. Yet our societal discussion and public policy lacks nuance. It is polarizing even among scientists. Neuropsychopharmacology asked me and another scientist to really evaluate the evidence in this circumspectives piece that they have every year. And the title was, Does Cannabis Cause, Exacerbate, or Ameliorate Psychiatric Disorders? An oversimplified debate discussed. And we picked psychotic disorders and PTSD to evaluate the data and come up with our opinion. And what's so interesting and demonstrating how polarizing this topic is here we're both senior scientists, we both evaluate pretty much the same data, and we come to different conclusions. Another example of how it's a miracle cure or hazard is every summer I go to two conferences. One is the College on Problems of Drug Dependence, and there I hear how cannabis, is a drug of abuse associated with psychosis and all sorts of things. I then go to the International Cannabinoid Research Society, and that is where it is the greatest thing that ever happened. And when I gave a talk describing cannabis withdrawal, I was hissed at by scientists. Other scientists didn't like to hear me say anything bad about cannabis. So cocaine is not like this. It's not nearly as polarizing, but cannabis is really like a religion to people. And if you say anything that isn't exactly to their view, it's a problem. So let me just start by defining a lot of the terms I'm going to be using. So first, there's phytocannabinoids. These are the compounds from the plant. So cannabis is a hemp plant containing over 100 phytocannabinoids. These are C21 compounds present pretty much uniquely to cannabis. The plant also has things called terpenes and flavonoids, which give it the smell and the color that you associate with cannabis. And there's huge debate in the field as to what role these might play in combination with cannabinoids to produce a particular effect. That's called the entourage effect. Very little data, but it's really taken over in the ideas around cannabis. The one cannabinoid we know the most about is delta-9 tetrahydrocannabinol, or THC. So when I talk about THC, I'm talking about delta-9 THC. It's the primary psychoactive component. Everything you think about the cannabis high is really delta-9 THC. And it's how we define potency. So that's something that's changed tremendously over time. So in 1979, average street marijuana that was picked up by the police had between 1% to 4% THC. In 2014, average marijuana contains 12 to 19% THC. This is just in the flower of the plant. And of course, you can get much more potent than that if you're willing to pay for it. But what's really changed are these concentrates. So now there's distillates that you can use. It's THC oil, or it can be something called dab or shatter. It's this wax distillate that people smoke that's 80 to 90% THC. So this is a whole other ballgame, really, in our understanding of cannabis science and cannabis effects. And there's so much we have to learn about that, but as you'll see in my further description, studying this is almost impossible. So the second cannabinoid that's receiving a lot of attention is cannabidiol. So cannabidiol is very different from delta-9 THC. It has a completely different mechanism of action. It's not intoxicating. It's for years they said it's not psychoactive, but more recent studies show that when you smoke or vape cannabidiol, there is an effect. It's just very different from the effects of THC. It's not really a high. It's just an effect that every single participant says they can't describe, really. But there is something psychoactive about it. It's just not well understood. But it's typically in very low concentrations in recreational cannabis. So the FDA has approved 3 cannabinoids to date. These are oral capsules. Since the 1980s, there's been 2 oral capsules, dronabinol and nabilone, that were approved for anorexia, nausea, vomiting associated with AIDS and chemotherapy. Dronabinol is just synthetic THC, and nabilone is a synthetic THC analog. And I will be talking a lot about nabilone. I happen to like it. I like it more than dronabinol for a variety of reasons. It's a better medication. It's more bioavailable. But more recently, there's been a cannabis plant extract called Epidiolex that was approved, and it's approved strictly for severe childhood epilepsy, but it's the only study with CBD that's been done in the appropriate placebo-controlled way and has been demonstrated to be superior to placebo. And then we have the endocannabinoids, and this is, I think, what is so exciting. This isn't, cannabis is an old drug, but this is really a new science. It wasn't until the 1990s that the first cannabinoid receptor, the CB1 receptor, was cloned and localized. And the CB1 receptor is really everywhere in the brain that we care about for psychiatry. It's in areas associated with memory, reward, mood, nausea, vomiting, obviously, appetite, and higher cognitive function. I think it is the most ubiquitous G protein coupled receptor in the brain, so it's everywhere. And our understanding of its role in brain development is burgeoning, but there's still so much we have to learn about that. So this is where THC is binding and producing, again, the classic THC effects, a THC high. In 1992, the first endogenous cannabinoid was discovered. This is called anandamide by Raphael Mechoulam, and he named it anandamide because ananda means bliss in Sanskrit. So that's how he created the name anandamide. In 1993, the second cannabinoid receptor was discovered. This is the CB2 receptor, which really isn't present in the brain very often, or only under really pathological conditions with neuroinflammation. You might see some CB2 present in the brain. It's really associated with the immune system, and it's primarily in the periphery. CB1 and CB2 are all in the periphery as well, by the way. But in 1994, cannabinoid antagonists were developed, and that's where I got into the field a little bit, or got interested in it, because this was the first time that animals that were treated with THC and given this antagonist, there was precipitated withdrawal. And it kind of rocked us at the time. Nobody really thought that something like that was possible with THC. And the following year, in 1995 is when they demonstrated that you could precipitate withdrawal. And it was sitting with Marion Fishman, who founded our division with Herb Kleber and Sandy Comer. And we were talking about these data because they were so exciting. And Marion said, we should really study this. And this is my recollection anyway. And I said 3 words that changed the course of my life, which was, I'll do it. And, and that changed the course again. So if you're a young scientist, try to say those words as often as you can. So then in 1995, the second endogenous cannabinoid was discovered. It's called 2-AG. It's actually present in much higher concentrations in the brain than anandamide. But again, we're really starting to understand the role. Yes.
When you say withdrawal, it's not a classic withdrawal like you see with barbiturates or opiates.
It's a real precipitated withdrawal. I mean, in animals, there's a classic set of symptoms, and in humans, we see a time-dependent, pharmacologically dependent, reversible with low doses of THC. You see a real withdrawal phenomenon, and you see it with animals too.
Why don't you get tolerance to the intoxicant effect?
You do. There is tolerance. Yeah. Yep. Definitely. We see a lot of that in the lab with the participants we study, and I'll be showing you those data. So what's exciting for the field now is that you can manipulate endocannabinoid levels with the enzymes that break them down. So anandamide is primarily degraded by fatty acid amide hydrolase, or FA, and 2-AG is metabolized by MAG lipase. So you can inhibit, in animals it's been shown in many studies that if you inhibit either of these enzymes, you increase brain endocannabinoid levels and you have behavioral effects. So in animals you see reduced anxiety-like behavior. There's really a lovely story with the role that the endocannabinoids play in the amygdala in modulating anxiety. So you can reduce anxiety-like behavior with these inhibitors. There's also evidence, this just came out and got a lot of attention, that FA inhibition enhances fear extinction learning in humans. It was a study with a human laboratory study, not in patients, but it certainly has a lot of implications for PTSD, OCD, where you're really focusing on enhancing extinction learning. And FA inhibition also reduces signs of cannabinoid withdrawal in THC-treated mice and also in humans. And in fact, Francis Levin, who and John Mariani, who have led the field in doing clinical trials with cannabis use disorder, are currently participating in a multi-site study looking at FAAH inhibition to treat cannabis use disorder. So now in terms of society, so this is what the country looked like in 1996 when California decided to legalize medical marijuana, although it is illegal federally, but they passed, California is usually good at starting the ball rolling, and they started the ball rolling for cannabis. And this is what we look like now, where many states now have legalized recreational and medical use. Many states have just medical use. And some have medical use, but in low THC versions, more CBD. So there's really only 2 states that have not changed their laws at all regarding cannabis, not even in terms of decriminalization. And all of these societal changes have happened with very little scientific input. So I'd just like to touch upon the legalization versus medicalization question, because these issues are often muddied, but they're really very distinct. So in terms of legalization of recreational use, this is perfectly within the purview of what voters should decide. As a country, ideally, you would discuss the pros and cons of having cannabis illegal and make a decision with the risks and benefits, do we legalize or not? That discussion never really happened, but nonetheless, it's within the voters' purview. But legalization of medical use should not be. Cannabis has escaped the process required of every other prescribed medication, which is randomized placebo-controlled evidence. And when I say cannabis, I'm also including cannabidiol in this. Should decisions about what constitutes an efficacious medication be decided by vote? So with the state of affairs right now, we have cannabis deemed efficacious to treat anxiety and migraines in New York, but not in New Jersey, but not New York. So each state has its own medical conditions for which cannabis is available to treat. Just imagine if penicillin was, legal in New Jersey for bacterial infection and New York for migraines. It's a completely different indication. It's not the way we should be making decisions about medicines. So in terms of this scientific vacuum, the societal changes have far exceeded placebo-controlled evidence. We don't know bioavailability of the different routes of administration. Again, cannabidiol is a good example. Add it to your coffee, rub it on your elbow, vape it, drink it. It's all going to change its bioavailability. It's not an issue. My hairdresser sells cannabidiol conditioner. There's cannabidiol candles. So I don't know how that's getting into your body, but if it's slapped, you slap cannabidiol on it, you're going to sell. We don't know anything about dose for each indication or what the role the differing THC and CBD ratios have. So I am not coming at this against the potential for these cannabinoids. It's just I'm driven a little bit crazy as a scientist with the absence of science in the discussion. So we need randomized controlled trials using a product of known composition, but these studies are almost impossible to do. The statewide legalized recreational medical use does not extend to scientific studies. So all the changes happening in society has made life actually harder as a scientist to study it. So Daniele Piamelli, who was at Columbia once, but he's a leader in the cannabis field, says, he lives in California, he said, so in California, an adult can have up to 28.5 grams of cannabis, which is a lot of cannabis. And he says, so that means everyone in California can now use marijuana except scientists who want to study it, not smoke it. You can go down the street and buy it to smoke yourself, but you can't study its effects. To study it, you have to study marijuana that comes from a farm in Mississippi. It's the only cannabis you can study as a scientist. So because cannabis and its constituents are Schedule I, except for Epidiolex, the only way as a scientist you can study cannabis is to get it from this DEA-approved farm in Mississippi, and you have to account for every milligram. So to get this marijuana, you need your own federal and local DEA and state licenses, and they come inspect your facility and make sure that it's appropriate to store. You need FDA approval for each protocol. So the FDA has to say, okay, the cannabis you're testing is safe and your procedures are safe for this particular indication. As an aside, there is no source of cannabidiol for scientific study in the United States. So if I wanted to do a study with cannabidiol, I'd have to import it from another country, which is exactly what we're doing, actually. So right now, scientists can't even study cannabidiol, even though the country's gobbling it up all over the place. So cannabinoids, including oral CBD, has to be stored in our facility. They're stored in a gun safe in a double locked and alarmed room. And the current regulations that have gotten harder is each Schedule I licensor needs her own safe so if 3 of us are studying cannabis, according to the DEA, we each need our own safe. The biggest problem in terms of addressing all the societal changes is how do you really study chronic conditions? So if it's being used for, diabetes and IBS and all sorts of things, how can you study it chronically when we can only give it in the laboratory, and then when you're finished smoking it, take the butt and store it back in that gun safe? You can't get a sick population to show up in the lab 3 times a day to get the cannabis for you to be able to do a placebo-controlled study. So there's all these limits. This is why we're in this kind of crazy place. And my final point on this is because cannabis is illegal by federal standards, including cannabidiol, by the way, it's not safety tested like pharmaceuticals, it's not subjected to agricultural safety and pesticide standards like crops, and it's not held to labeling standards like alcohol. So you don't know what you're getting for the most part. Less than a third of edible cannabis in dispensaries or CBD purchased online is accurately labeled regarding cannabinoid content. That's really important. People are giving it to their children, pregnant women are taking it. You don't know what you're getting. It's morphed into this large-scale for-profit industry, and in lieu of evidence, the medical benefit is what marketers say it is.
Meg, is
Yes.
it being marketed as a nutritional supplement or nutraceutical?
That's an excellent question. The FDA hasn't decided yet, but my understanding is because Epidiolex is a medicine, they're kind of forced into treating this as a medicine as well and not a food. The Epidiolex kind of locked it in. Once you have one cannabinoid, a medicine from the plant, but they're kind of all over the map with it right now. The FDA remains too silent on this issue. To their defense, they are not comfortable with us going to Whole Foods and buying CBD and then testing it because we don't know what Whole Foods is actually selling. We don't know anything about the provenance of that CBD, what it contains, pesticides, heavy metals. We don't know any of that. FDA wants to make sure it's all clean and safe, but with that, we're just hamstrung by only being able to study what's on that farm. So the only thing that I'm hopeful for is Congress is finally stepping in because the DEA and the FDA have not budged on this issue, and we're stuck as scientists.
When you say can't get a pure source of CBD, you could get the source that's being marketed, though.
We don't know if that's pure.
Yeah, you just don't know. I mean, it's not GMP grade.
Correct.
But
And that's what the FDA wants. For good reason. If you're going to be giving it to sick people, you want to know what you're getting,
But I mean, for research, couldn't you assay it to determine content?
Yeah, you could, but what the FDA wants is that for everything about the facility to be GMP. So they want all of it to be clean as a whistle, not necessarily the end product. So it's a bit of a mess. Nonetheless, despite all these problems, it's actually an incredibly exciting time to be studying cannabinoids. As I said, it's an old drug and a new science. In the past 20 years, there have been marked advances in our understanding of endocannabinoids at the synaptic level, at the role that endocannabinoid signaling has in the development, maturation, and sculpting of neural circuits into adolescence. There's so much to learn. And this review, I was able to be an editor on this neuropsychopharmacology review, and it really covers, again, from synapse to epidemiology. Debbie Hassan has a great article in there. Francis Levin does too. And it really covers whatever your interest is. There's an article on the most up-to-date research on this topic. Okay, so I'm going to move to the yin or the yang. I'm not sure which one, but talk about cannabis use disorder first. So this is pretty remarkable. 21% of U.S. citizens right now live in states where recreational cannabis is legal. And with this legalization, there is increased public acceptance, obviously, a steadily increased potency in leaf and extracts. And daily cannabis use and cannabis use disorder among adults is rising. And cannabis use among pregnant women is really rising. There's studies showing that you can call a dispensary and say, I'm pregnant and I'm nauseated, and every single one of them will recommend cannabis for you to help with that. About 30%, this is Debbie Hassan's data, of those smoking cannabis in the past year met DSM criteria for cannabis use disorder, and it's estimated about 4.2 million have it currently. And a subset of those with cannabis use disorder are seeking treatment. There's about 300,000 treatment admissions per year presenting with cannabis as the primary problem, and its reasons are more subtle than cocaine or opioids or alcohol. There's a general dissatisfaction with functioning. People smoke more than they intend to. There's memory effects. They undergo withdrawal. They have health concerns. They neglect responsibilities. And what's surprising to most people is that they have great difficulty stopping. So relapse rates for people with cannabis use disorder are as high as they are for other drugs of abuse. Again, the consequences of cannabis use disorder are not as severe as opioids or the other drugs, but they're distressing to a significant number of people. And in many ways, it's qualitatively similar to other substance use disorders. There is withdrawal, it's disruptive, and it's persistent. And there's no efficacious treatment. So few patients achieve long-term abstinence, even with evidence-based behavioral treatments. The randomized placebo-controlled pharmacological trials are also consistently negative. So finding effective treatments for CUD is a public health priority, particularly as rates of the disorder rise. And we think that a variety of treatment approaches are needed, including medications to reduce withdrawal and to facilitate abstinence, as we have for other drugs of abuse. So at PI, we have this incredible resource called the Residential Laboratory that this is where we've done the bulk of our work over these 25 years. And it's really a translational bridge between the preclinical lab and clinical studies. So we can study in a very intensive way in a small number of people the combination of active and placebo cannabis and medications in daily cannabis smokers using this within-subject design. And so we have participants, we have 4 move in at a time. They each get their own bedroom with a workstation and a place to prepare food. And then we have a social area. And so we structure it to be like a typical workday. They're working and doing cognitive tasks and mood scales on their computer during the day. They ad lib eat, and we're getting very good data on their food intake. And we have objective data on their sleep. So we're really measuring their behavior around the clock. And importantly, the behavior that is of most interest to me, particularly as a signal for a potential medication, is we look at cannabis self-administration. So if you see these lights on the wall, is how we have people smoke cannabis. So at set periods of time during the day, we give each participant their own cannabis cigarette lighter and smokeless ashtray, and we guide them through the lights on how to smoke. So the red light tells them to light it, the green light tells them to prepare, the blue light to inhale, and then the yellow light to hold the smoke in their lungs, and when that goes off, they exhale. So we're able to control how they're smoking and then measure the time course of cannabis effects after they smoke. We have cameras and microphones throughout, so we're really observing this from the next room. And the people we enroll are heavy cannabis smokers. They're non-treatment seeking. They smoke marijuana or cannabis every day, averaging 2 to 4 grams a day. And the reason we're focusing on this group is if they're lighter users, and I'm looking to see if a medication can disrupt their drug-taking behavior, it would be easier to do if they're lighter smokers. So this group they're hardcore. They smoke all day throughout the day, and so if I can shift that behavior, I think that that's going to be a good signal for the clinic. To be enrolled in the study, they can't have any other major psychiatric disorder. They have no other substance use disorders, except the majority of them do smoke cigarettes. I don't have time to talk about it here, but that's actually very, very important for their actual trajectory. They fare worse in many ways when they're cigarette smokers. But what's so interesting is that they really don't like, I'm always struck by how little they like alcohol. Their alcohol use has got to be lower than the average person. They're very strictly cannabis smokers. They invariably drink just a handful times a year. They don't drink very much at all. And so the studies are double-blind. They're told that the cannabis and the capsule strength may change at any point, but they don't really know the overall objective. So when you're developing medications, you pick out medications and you want to target certain aspects of problematic drug use. So one thing to target is relapse prevention. So this is in abstinence users. If you give them their medication, can you decrease withdrawal symptoms and reduce the likelihood that they'll return to cannabis use? Or there's abstinence initiation. So these are ongoing users. If you can reduce maybe the rewarding effects of cannabis, can you decrease their use and increase the likelihood that they'll quit or at least reduce their use considerably? So I first want to describe to you our approach with relapse prevention. That's been the bulk of it. And so with that, I just wanted to describe cannabis withdrawal. And again, because of that residential lab, we were one of the first to be able to demonstrate a withdrawal syndrome in 1999 from smoked cannabis, because we were able to give people active marijuana and then switch it to placebo and then really track all those behaviors around the clock. So cannabis withdrawal is characterized by anxiety, irritability, depressed mood, and restlessness. There's a marked decrease in food intake and sleep quality. Sleep is really disrupted. And because THC has this long half-life, it takes a little while to kick in. It's not like cigarettes where you go several hours without smoking and you really start craving. It usually takes at least 24 hours to kick in, peaks around days 2 to 6, and lasts 1 to 2 weeks. And it contributes to the maintenance of daily cannabis use. So we discovered early on that decreasing withdrawal symptoms alone, without focusing on shifting drug taking, was not predictive. So we found that dronabinol, or oral THC, given at low doses throughout the day, very effectively decreased cannabis withdrawal symptoms. But then when you looked at self-administration, it didn't shift drug taking. And Francis Levin and John Mariani, in doing the clinical trial, found exactly the same thing. So among treatment seekers maintained on dronabinol, their withdrawal symptoms went away, their retention in the study went up, but they didn't shift their drug taking. So withdrawal alone is not enough. We need something that's going to actually shift drug taking. So we developed a laboratory model of relapse where we structured the conditions so that abstinent cannabis smokers had to pay actual money to return to their cannabis use, and looked at a range of drug effects. And so this is kind of all the placebo-controlled human laboratory studies done, and we're representing most of them here, but in terms of discouraging, lots of discouraging, and encouraging, the superstar for us has been nabilone. This is off-label testing. And so nabilone was able to reduce withdrawal and also affect self-administration. So just to orient you to these slides. So this is, on a day I'm giving them active cannabis and looking at the effects on ratings of I feel irritable with a maximum score of 100. So when they're smoking marijuana, they're mildly irritable. When they're going through withdrawal, they're abstinent for several days. Their ratings of irritability go up under placebo nabilone conditions, but the 2 active nabilone conditions just return them back to normal at a dose that didn't produce any intoxication. So this is, again, a THC analog. It has the potential, certainly, to produce abuse-related effects, but it's a very slow onset, long-duration agonist, and it doesn't have a lot of abuse liability. This is the sleep data that I was talking about. So when participants are smoking cannabis, they sleep pretty well. When they go through withdrawal, they don't. They don't sleep well. They sleep fewer hours. They wake up frequently, and their sleep efficiency is down. And nabilone just, again, restored that. Food intake, again, just a good example of what happens when people are going through withdrawal from cannabis. Under conditions of cannabis smoking, they were consuming over 3,500 calories a day. When they were abstinent, it went down to, about 2,200 calories a day, a really dramatic decrease. They have a hard time eating when they're in withdrawal. And nabilone just, again, restored that. And most importantly, it decreased self-administration, the number of puffs of cannabis self-administered. So again, this has been the star of all the medications we've tested, in that decreased withdrawal and decreased relapse. So we're hoping that this can then be tested in a clinical trial. So then, just in terms of the other approach, which is abstinence initiation, you want to decrease the positive subjective effects of a drug. So we've tested three medications, cannabidiol being one of them. Naltrexone, I didn't have time to talk about. We actually got very good data with maintenance on naltrexone, but unfortunately I didn't have time for it, and I'm going to describe this pregnenolone analog that we're doing right now. So if you're trying to decrease the rewarding effects of a compound, obviously what one would go for is a cannabinoid receptor antagonist. And there was one available briefly called rimonabant. It was a CB1 receptor antagonist, and there was some evidence that it decreased the certain of cannabis's effects. But the drug didn't last very long. It got pulled from the market. Blocking that CB1 receptor for weeks at a time produced increased ratings of depression and anxiety. It was pulled from the market, and anything like it was pulled from the market. So it took this one tool away from us and to be able to study it. But it is pretty impressive to think if you block this endogenous cannabinoid system, which is everywhere in the brain, you are having consequences on mood. So cannabidiol, the reason why we tested this, and again, just to introduce its mechanism of action, so cannabidiol does not bind to those CB1, CB2 receptors, but hardly at all. It has very low affinity for them. It is a 5-HT1 agonist. It's a TRPV1 and TRPV2 agonist. Seems to inhibit anandamide uptake and hydrolysis, but it's a very murky mechanism of action. We don't really know how cannabidiol is working in many cases. There were a few studies suggesting that one dose of oral CBD was decreasing the intoxicating effects of one dose of THC. So with that, NIDA said, well, let's see, maybe this is a potential medication. If cannabidiol can decrease the rewarding effects of marijuana, maybe we have a medication we can use. So we ran a multi-site study because no study to date had tested a range of oral CBD doses in combination with smoked cannabis. So we had to import this. We had to import it from the UK, and we tested 0, 200, 400, and 800 milligrams and looked at a range of effects in combination with placebo and active cannabis. So this figure just shows after smoking inactive cannabis, these are the doses of cannabidiol. You see a classic placebo effect. So there's no THC in this marijuana, but they're feeling a little bit of something, and cannabidiol doesn't do anything to it. And when they smoke active cannabis, they feel more. I feel high, but cannabidiol didn't do anything at all to that. And nor did it change any other aspect of cannabis effects or cannabis self-administration. When people smoke active cannabis, you get this very reliable increase in heart rate, and CBD did not alter that. And importantly, we were getting plasma levels of CBD that were well within the range or above the range that others had shown in their studies. So we don't think it was related to that. So CBD does not seem to work. We got classic cannabis effects, and CBD didn't do anything to that. So that one's crossed off the list. The medication we're testing right now is a pregnenolone analog, and it's got a really intriguing mechanism of action. So as I mentioned, rimonabant is an orthosteric antagonist. It blocks all receptor activity and consequently produces a lot of negative side effects. Pregnenolone, so my colleagues in France, when I was in France in the 90s, more recently discovered that pregnenolone, the steroid hormone, binds to a specific intracellular site on the CB1 receptor, distinct from where THC and other CB1 agonists bind, and acts as a signaling-specific inhibitor of the CB1 receptor. So I can kind of show you how this works. So this is the CB1 receptor. THC binds, and it sets off this cascade of intracellular effects. And pregnenolone, they discovered, binds to this other pocket without affecting how THC binds. So THC is still binding as it normally would. It's not modulating that at all. But with pregnenolone on board, it's certain of the secondary messenger effects are happening, but not all of them. And by blocking this one signaling specific effect, there's evidence in animals that it was blocking all the abuse-related effects of cannabis without producing any of the negative effects that rimonabant did. So rimonabant binds the same place as THC and just shuts it all down. So they spent a lot of time developing a medication, and this is called AEF0117. The company is called Aelis. It's a non-metabolized pregnenolone derivative because pregnenolone itself is a poor medication. It's got a short half-life. It's metabolized to other steroids, low oral bioavailability. And AEF has a very large safety window. It attenuates THC effects in preclinical models without producing the problems that rimonabant did. Does not precipitate withdrawal, does not decrease food intake, and does not increase anxiety measures like rimonabant does. And importantly, from my perspective, it decreased cannabinoid self-administration in both rats and monkeys. So we were able to get a strategic alliance from NIDA where we were able to move this medication from the preclinical world into humans. So we first did phase 1 safety studies, single dose and multi-dose, testing a range of doses. Once it was deemed safe enough, we had permission to test it here at PI in the lab that I just described. And so these are the studies we're currently doing. We administer the medication in the morning, administer cannabis, a controlled amount later in the day, and then just measure all of the effects that are related to abuse liability. And we're really excited to see what this new approach might do. So just to conclude this section, the medications development for relapse prevention, it looks like nabalone's a star from the work in our lab. And abstinence initiation, we can rule out cannabidiol. Naltrexone looks promising, and AEF is to be determined.
Meg, can I ask you a question?
Sure.
The, is THC inducing both the cyclic AMP and the beta-arrestin? And pregnenolone, what's the relation of that to, this medication that Sage is using for postpartum depression? Brexanolone.
What's the name of it?
Brexanolone. It's an allopregnenolone derivative.
Yeah, I think that's acting at a different, I don't know, but I thought allopregnenolone was working more at the GABA site. Am I right on that? Yeah.
Probably.
Yeah, as far as I know, it's not acting at the CB1 receptor, but I'm not 100%. Yeah.
So is pregnenolone a neurosteroid? So it's endogenously synthesized in the brain?
Yeah, and so they originally found this because when they gave rats very, very high doses of THC, pregnenolone got endogenously released at very high doses and shut down a bit the CB1 receptor. So they were thinking this is one of the reasons, it's not really the reason why THC doesn't produce overdose, really. That's because the CB1 receptor is not really in the areas responsible for respiration and that sort of thing. But they thought it was the body's way of handling almost too much THC. It shut the receptor down. Pregnenolone gets released, and it kind of shut down a portion of the receptor.
Do you know what pregnenolone does to THC-induced dopamine release?
No, I don't. Yeah. But it's, again, all the measures of abuse liability with cannabinoids were completely shut down by pregnenolone, so you might infer that it's closing that down too. Okay, switching to the yang section of the talk. So as we all know, marijuana cures every single thing that is wrong with you, for you and for your dog. This is a slide I stole from a woman at night, which characterizes all the different, if you add up across states, all the different things marijuana or cannabinoids are approved for within the states. It's 51 indications. So you know what other medication treats everything? Placebo. So the National Academy of Sciences did a really important study where they tried to just look at all the data for every indication and do a very comprehensive review of the health effects and potential therapeutic use. And they really wanted to evaluate the quality of the data, and they concluded that there is conclusive or substantial evidence that cannabis or cannabinoids are effective for the treatment of three things: chemotherapy-induced nausea and vomiting, patient-reported MS spasticity, not objective measures of MS spasticity, but patient-reported, and chronic pain. Now, that's not to say all those other indications that it doesn't work for them. It's just that there's no good data to evaluate. So that's where we really are, where we need to go. So we have done 4 studies approaching this medical cannabis question because we can. We have the capacity to give people both placebo and active cannabis with different concentrations. And so it all started really, Richard Fulton and Judy Rapkin participated in this as well. This was over 10 years ago, and where we were looking at food intake in people with HIV. Because at the time, as a scientist, again, I was extremely annoyed that people were saying dronabinol does not work for, the low appetite that individuals with HIV had. And it wasn't based on any data, it was all just based on anecdote again. And it might be true, but I didn't like anecdote driving the policy. And so, again, since we had the capacity to test this, we wanted to compare the tolerability and efficacy of smoked cannabis and oral dronabinol in HIV-positive participants and measure a range of things: eating topography, body weight, mood, all sorts of things that we're able to measure in the lab. And we went through a painstaking process for controlling for the expectancy effect, which is what you have to fight so much with cannabis. So these poor subjects lived in our residential laboratory for 16 days straight, got a 5 to 10 day vacation, and then moved back in for another 16 days. Each day, they would smoke cannabis 4 times a day and take capsules 4 times a day. First 4 days would just be placebo everything, and that just gave us a good baseline. Then we'd have active cannabis 4 times a day, placebo dronabinol, back to placebo everything, and then we'd have active dronabinol, give them a break, and then switch the dose of everything. And we had the dronabinol, they took it an hour before the cannabis. So in case the dronabinol was active and they smoked placebo cannabis, they couldn't really tell what it was that was getting them high, because the timing was matched. So after all that, what we were able to report was that both worked pretty well. Here are caloric intake on placebo conditions. They consume about 2,500 calories a day. This is low-dose dronabinol, high-dose dronabinol, low-strength cannabis, high-strength cannabis. Everything worked. Both dronabinol worked well, and people gained weight. Their GI symptoms went down. This is, again, I harp on that placebo effect. So here their ratings of I feel a good drug effect. With placebo everything, they're rating 30 out of 100. I feel a good drug effect. Low-dose dronabinol didn't do much. Higher dose did. Cannabis always gives you a good drug effect. So that it always has higher abuse liability. So just to conclude the food intake story, they both worked. When you do the studies, they both worked. So the anecdotes were incorrect. There can be some intoxication, but there's no evidence of discomfort or cognitive impairment. So here we were just able to look at the pharmacological effects without the confound of expectancy. So next, experimental pain, the second therapeutic use I wanted to talk about. These studies were really spearheaded by Ziva Cooper, who has now since moved to UCLA. But this is such an important topic because cannabis is one of the primary reasons people use, pain is one of the primary reasons people use cannabis. So she also did this placebo-controlled double dummy approach to compare smoked cannabis to dronabinol on an experimental measure of pain. Didn't want to work with a pain population yet. Let's just first look at the data and see what we can get. And we use the cold presser test. You just put your hand in cold water, and we time how long it takes for people to say, that hurts, and then how long it takes for them to take their hand out. And so this figure shows the time course of cannabis. So this is the pain threshold, how long it took for them to say, that hurts. This is the open is placebo. This is the low-strength cannabis, and this is the high-strength cannabis. So shortly after they smoke, you see a nice analgesic effect of the high-strength cannabis. That doesn't last terribly long. And this is dronabinol, just matches the time course, but you get the same magnitude of effect. So both are doing pretty well in this model. This cold presser test has good predictive validity. Again, when you look at the abuse-related effects, it's just marijuana that's really giving you. The high-dose THC did, but marijuana is always better for that. So the next question is, so cannabis produces some analgesic and abuse-related effects in this laboratory model. What does it do in combination with opioids? This is a really hot topic right now. And so Ziva had people come in on 6 occasions. Each occasion they would smoke cannabis, either placebo or active, and take a dose of OxyContin. It would be 0 or, this is subtherapeutic, it doesn't produce any effects on its own, 5 milligrams does, and combine it with all and see what we could get there. And so what she found, this is the low dose of OxyContin, so placebo doesn't do much, OxyContin didn't do much, the cannabis didn't do much, but the combination did a lot. So that's very intriguing and very hopeful. I mean, ideally, this is, of course, a very limited sample, but the idea that you could take less opioid if you combine it with cannabis is promising. When you looked at the higher dose, which was analgesic in and of itself, we'd not see that enhancement. And in fact, the higher dose of cannabis tended to reduce the effects of OxyContin when combined with the higher dose. So its subtherapeutic doses look promising. The good news is there was no enhancement. There was an enhancement of analgesic effect, but no enhancement of the high or the abuse-related effects. So again, combining cannabis with OxyContin didn't do anything to the high. Cannabis alone produced that high, and OxyContin didn't enhance that, just enhanced the analgesic effects. So the fact that we didn't see an enhancement is we have to add the caveat that these were not opioid abusers. These were cannabis users. They had used opioids, but they weren't using them for abuse-related reasons. So both Ziva and Carolina Root, a young faculty member in our division, have an R21 right now to pursue this further, looking at low-dose OxyContin when paired with cannabis with all different THC and CBD ratios. So we have that opportunity, and it's vaped cannabis.
Can you block the effects with naltrexone?
So the only way we found, you could block the effects of OxyContin for sure with
No,
naltrexone, but that combination effect, yeah, we don't know.
Or THC?
So what we found with our other studies, that we reduced the intoxicating effects of THC when you maintained people on naltrexone for about 2 weeks. They self-administered less, and their good drug effect from cannabis was less when you had naltrexone on board. The pain effect, yeah, to look at that potentiation, my prediction would be you would, because you're going to be blocking the OxyContin contribution to it at the very least. But I don't, we haven't done that study. So now another collaborator, and this collaboration was born out of watching Blair Simpson give grand rounds up here, because she had been touching upon the endocannabinoids and OCD, and again, I have the opportunity to give cannabinoids, but now Riley Kaiser has really been spearheading this series of studies that have been very interesting. So we know CB1 agonists and FA inhibitors facilitate fear extinction learning. So this pilot study tested the feasibility and preliminary efficacy of nabilone, again, for 4 weeks in people who were getting the exposure and response prevention therapy that has been shown to work when given for, I guess, 8 weeks or longer. So people got either nabilone for 4 weeks, they got nabilone for 4 weeks either alone or with this exposure therapy. And as a comparison group, looked at a group that just got the exposure therapy without any nabilone on board. And the results are really interesting. So nabilone alone didn't do anything to measures of OCD, the Y-box score. So nabilone alone didn't work. The exposure therapy alone, after 4 weeks, it usually takes longer. 4 weeks isn't long enough time. But when you combine the exposure therapy and nabilone, you see this very nice enhancement. So suggesting that you could get the effect you want in a shorter period of time, in 4 weeks versus 8 weeks. At 8 weeks, the exposure therapy alone got up there, but this could be a tremendous improvement in treatment outcome if you could get people to get better faster. So Riley's certainly going on to pursue that idea. The second study asked a different question. So in people who are having symptoms throughout the day, if we have them come into the lab, give them different cannabis combinations, have them smoke that in the lab, and then just look at their symptoms while they're there, their acute symptoms. They came in on 3 occasions. They got high THC, low CBD cannabis, high CBD, low THC cannabis, or placebo. And the results were not what we were expecting. We saw no reduction in OCD symptoms in either of the active conditions, the THC or CBD conditions. And in fact, what we found was over time, so people came in with the same level of anxiety. So this is anxiety symptoms. Over time, under placebo conditions, those symptoms went down. In either active CBD or THC conditions, they stayed higher. So there's actually an enhancement of anxiety as compared to placebo. So I think that this just highlights a critical point. When you listen to the medical cannabis field, it's often discussed like cannabis isn't anxiolytic, and it really is not. It is for certain people. It's for those who use it for that reason, it can be. But many people get more anxious. Many people are uncomfortable with the effect. Even though these individuals smoked cannabis on occasion, it doesn't work universally for everybody. You really have to understand dose, route of administration, and the particular diagnosis. So this doesn't entirely surprise me, but I think it's an important message to get out there. If you look at emergency room mentions, rates for cannabis are very high, and it's not for anything life-threatening, but it's panic and anxiety. It's people getting higher than they're comfortable with and having a panic attack. So it's not anxiolytic for everybody. Finally, this is the last study I'm going to describe, and this is with Diana Martinez, and it's really out of our lane a bit because we're looking at taxane-induced peripheral neuropathy. This is a common condition and occurs in the majority of people treated for breast cancer. There is no effective treatment, and tragically, a lot of women stop their treatment because it's this this incredible discomfort. And there's really amazing preclinical data looking at CBD and or THC pre-treatment. There's evidence to show that if you treat animals with CBD or THC or a combination of the two prior to paclitaxel, you prevent the development of this mechanical sensitivity. And the mechanism we know here is just 5-HT1A. And those who already have, animals that already have this TIPN, both cannabinoids reduce it significantly. So we have the opportunity, thanks to the Thompson Family Foundation Initiative and a lot of Diana's chutzpah to get us moving on this. We've imported from Canada a pharmacological product from Tilray, where we know exactly how it was made. The FDA is comfortable with how Tilray makes their products. It's high CBD, low THC cannabis capsules, and we're going to compare to placebo. Daily, we're going to give it daily for 8 weeks in women with TIPN and get biweekly measures of pain and functional impairment. So I'm excited to be able to contribute a good, well-powered clinical trial to the field. So take-home messages, we're at the end. Yes?
Why didn't you use an active comparator like the Rhonda or something?
You know, we didn't have the power. That would have added a third arm to the condition. You know, just getting these 96 is going to be our job for the next year. And it's really proof. We just want to see if anything we get from this. So just to wrap up now, I know I'm getting close to the end of time. So in terms of medical cannabis, again, tremendous potential. Our understanding is really in its infancy. Inhaling a psychoactive substance that all of society is telling you is going to cure a range of ills is going to produce a robust placebo effect. There is a pharmacological effect likely for certain things, but that we have to handle that robust placebo effect. Bioavailability, dose, ratio. I didn't even talk about sex differences, but they're pretty important with cannabis. So just the marketing of cannabis and cannabinoid medical benefit by profiteers should be viewed with a healthy skepticism. In terms of cannabis use disorder, it's increasing among adults. It's something people don't know much about. I get a lot of calls from reporters who don't know that this is real. It's hard to quit once you reach a level of daily heavy use. And our research is really lagging behind. As I mentioned, Francis and John have been at the forefront of conducting most of the fully powered clinical trials. The only thing that has proven positive, so this is not a lot in terms of a problem that's pretty big. Kevin Gray has shown that N-acetylcysteine has worked in adolescents but not adults. So that's as far as we've gotten so far. Just lastly, the priorities. DEA seems unwilling to change Schedule I status to allow scientists to be able to study it. So with Nora Volkoff and the College on Problems of Drug Dependence, and Sandy Comer's been a huge player in this too, is working with Congress to try to change the rule. And there's a bill in Congress right now to allow scientists Schedule II status for cannabis products so that at least it can open up the field tremendously. We really need more tools, CBD, negative allosteric modulators, MAG lipase inhibitors. The CB1 receptor is ubiquitous in areas critical to psychiatry, so there's really so much to explore. And lastly, I really have to thank all of my colleagues as well as NIDA and Thompson Family Foundation. You know, you don't stay somewhere 25 years unless you really like the people you work with. So, and this takes a lot of work, this kind of study. And also colleagues outside the division, Judy Rapkin, Blair Simpson, Riley Kaiser, Yuval Naria helped us with the PTSD pilot, and Anissa, who's no longer here, but I wanted to add her too. Okay, thank you so much.
Meg, thanks for what a fabulous talk and a very impressive body of work. I'm going to start things off with just two questions. One is, so drugs or medicines have a lot of variability or heterogeneity in their effects, but it's pretty much constrained. I mean, when you give someone an analgesic, when you give someone an antihypertensive, when you give someone a antihyperthermic, it has an effect. Cannabis has really a much more varied effects on different people, which, bespeaks the possibility of pharmacogenetic
Right.
differences. Is anything known at this point?
Yeah, there's really exciting research, and I know SNPs are not in vogue right now, but there's very, very interesting with the Fa gene. So again, this is the enzyme that breaks down the anandamide, and there are people who have a gene a SNP where there is very little Fa, meaning that they have a lot more anandamide than the average person because nothing's chewing it up. And their anxiety levels are very low, their response to cannabis is very different than the average person who has a normal functioning. So there's something really intriguing about Fa that has a functional consequence. So that's one thing. And I think with anxiety, the data are pretty clear too, and there's knockout data too, that animals that have active Fa, for whatever, you can bump it up. So they're chewing up all their endogenous cannabinoids, have an anxiety-like phenotype, and they're different behaviorally. So I think Fa is a really important area.
At the research day that Blair organized last winter, I think, there was a poster from your division that showed the effects of RTMS at inhibiting cannabis withdrawal. When I saw this, I said, this is too good to be true. You didn't. It's a hard time about it. Well, I was waiting to see the paper or the replication, but you didn't show any of that data. What's the story?
No, I have, another young faculty here is continuing that study right now. We didn't have a big enough N at the time because Nina Urban left and we didn't finish it up, but Tanisha Carney-Ramos is finishing that study up right now, so we'll have more data to show you soon.
This is guided RTMS?
No, it's not guided.
There's a mic. There's a mic.
Oh, sorry. Okay. No, it's not. Are you referring to like MRI guided RTMS? No. So this is just using what's called deep RTMS. So it's an H-coil design, which basically you can apply using a helmet, and it has a very specific coil geometry that allows it to target the specific region. But in this case, it's not neuronavigation guided.
Is it, and I'm just mouthing words, is it theta burst?
It is not theta burst. We did get a new machine that has theta burst capabilities. So very recently, within the last few months, we got that machine. But this is just 10 hertz high frequency, which is supposed to enhance the activity in a brain region that's involved in decision making. And so the idea is that if we enhance that capacity, then we should be able to reduce the choice to smoke cannabis. So we measure that using the inpatient design where they can, where there's cannabis self-administration sessions where we do that pre and post TMS.
If that holds up, I'll buy somebody something.
So there's already quite a bit of research using TMS studying different forms of TMS in substance use groups. So it's been studied in cocaine users, in nicotine users. There's some newer studies in opiates, and then this is really one of only 2 studies so far that's studying it in cannabis. But there is some evidence so far that TMS can alter the neural circuits that are involved in reward processing and cognitive control, and that it does reduce abuse as well as craving and other measures of substance abuse.
I think this is, I'm not sure what lecture series this is. What is it called? The CTN something? It's a cognitive neuroscience. Yeah. And there was supposed to be a speaker today who got postponed to either October or November. Joan Camprad, the guy from MGH, who's a TMS guy.
Coming in October.
Is that right?
Yes.
What's his name?
Juan.
Okay. At any rate, so you should go to that lecture and grill him, okay?
Sounds good.
Yeah.
Other questions?
Tanisha's doing a great job with that.
So Debbie, so you've done all the epidemiologic studies, or the best epidemiologic studies. I mean, this is a kind of really a fast-moving target, and the other thing that complicates this is that the forms and the potency of the cannabis products are increasing. So, do you have any sense of where things are going or predictions?
I can say a few things about that. I'd also like to say, Meg, what a great talk. You covered so many different areas, and it's so great to see some evidence starting to come out about about cannabis. So, there are studies going on at this point that show that as states pass medical marijuana laws, the rates of cannabis use and cannabis use disorder increase in those states relative to other states that don't pass laws in the same year. And a paper that's going to be coming out in JAMA Psychiatry soon shows that the same effects are happening for recreational marijuana laws. So these, there are a lot of people that don't believe that a cannabis use disorder exists and don't know that cannabis withdrawal exists. People just really have a hard time wrapping their heads around this. And if they're on the sort of pro-marijuana side, especially bolstered by the industry, which is very interested in making money out of this and influencing state policies, people just, things are polarized, as you said. I was at a SAMHSA meeting a couple of weeks ago where there was discussion about how to start getting believable messages out about harms of cannabis as well as potential benefits. And one person said that, pregnant women are starting to use cannabis because they feel they need to responsibly help the fetus develop their endocannabinoid systems. So it's not just morning sickness, it's like crazy beliefs, So it's we've had a lot of cycles. We have cycles in alcohol, we have cycles in opioids. It'd be great if we start to get to a crest in the opioid epidemic at this point. One of the things I'm concerned about is that we're going to have to see some kind of a crest in cannabis-related harms before we know what we're doing with it. Hopefully not, but some of that stuff is increasing.
I see people back there, yeah.
That was a great talk.
Oh, thank you.
I've got a question about when heavy users of cannabis are coming into your studies, they've been using cannabis with 15 to 20% THC in it, and now you've dropped them down.
Right.
Do they have any, withdrawal in a
No,
way?
it's a really great question. And again, when I give a talk at a Cannabis Society meeting, they really hammer me about that night of cannabis. But the amazing thing about cannabis is how well users titrate. So we've actually done the study that the stronger the cannabis gets, the less hard they pull on that 5-second pull. So I can't get dose dependence. If it's weak, they just smoke more. If it's strong, they smoke less. So there's an incredible group out in Colorado that worked around this whole regulatory problem. That night I bought them a van. They go to people's homes. They tell them what to buy at the dispensary. They do baseline measures. The people go in their homes and smoke. They come back out and do all sorts of baseline measures. And the fascinating thing is 20% cannabis that they're smoking in plant, their plasma levels of THC are similar to ours. So they're just taking one hit where my guys are smoking an entire cigarette in one pull to get to where they want to get. So people titrate very carefully. So yes, NIDA needs to make higher potency cannabis, or we have to change the rules somehow. But hasn't been a terrible effect on outcome. I still get people getting high.
Jeff?
Oh.
Go ahead.
Oh, thank you for the talk. I just had a quick question about the pain aspect of it, because I know that pain can be acute and chronic. Is the ice bucket test? Is the ice bucket specifically chronic or acute measure of pain?
It predicts analgesic, so it works for gabapentin and opioids. So it predicts medications that will work for acute pain, I guess. Yeah.
Okay.
Yeah.
Do you have any other models for like a chronic model?
No. The woman who just left, we have a QST machine. Thank you to the department. We also got recently, it's another model of pain that we think is going to get at the chronic question better. Yeah.
Great, thank you.
Thanks.
Meg, that was a beautiful talk.
Thank you.
I had a question about, I think your leading abstinence induction medicine was that nabilone?
Uh-huh.
Right, so, and as an agonist, I'm just wondering how you think about that. I guess the clinical trials have to be done. Do you think about it as an acute, time-limited treatment, or as like a maintenance treatment, like methadone maintenance
Right.
with a longer-acting agonist?
Yeah, I mean, my thought is get people through the first 3 weeks of discomfort and then wean off from nabilone. I wouldn't think of it more like a methadone situation. It would be more acute. The tricky thing is, as the clinicians will say, is getting people abstinent to be able to give them a relapse prevention is tricky. Cannabis smokers don't want to get abstinent.
Yeah, what I would just add is that we would love to look at it for facilitating abstinence, and that Meg has beautiful lab data. I came in late, so I don't know if you presented the nabilone, but it's beautiful lab data. And we've submitted the grant multiple times, and up until this point, NIDA hasn't wanted to fund it. We were putting it in again, because we don't give up. Putting it again, John Mariani and I, in next week, and we're going to try. The problem with nabilone is it's so incredibly expensive. So it's like $4,000 a patient, even for 8 weeks. So thinking as a long-term med would be quite difficult just based on the cost. But
Yeah.
And it's much cheaper in Canada, but the regulations won't allow us to buy it from Canada.
It's cheap in Canada.
Yeah,
They
yeah.
control that much better.
In light of the expense of nabilone, can you comment on naltrexone as a clinically possibly viable option?
Yeah, I think naltrexone also deserves clinical study. It works a lot like it does for alcohol. So it's not naltrexone for opioids where it completely knocks it out, but it lowers the rewarding effects of cannabis, and it's certainly worthy of trying. Yes.
Here again. We did an open trial, and it did reduce marijuana use using Vivitrol, which would be a good thing to do. And we put that grant in, and that didn't get funded. So, like I said, besides the queen of negative trials, queen of grants that don't get funded. So.
But it was interesting. We were very, very careful about making sure people took their medication, because people don't take their medication. So we were very made them come in and take it in front of us. And so but it did take about 10 days for it to start to reduce the rewarding effects of cannabis. So it wasn't a blockbuster, but it certainly did something. It decreased self-administration and good drug effect, and it's cheap.
And a long-acting formulation has the advantage of that.
You don't have to worry about the compliance issue. Exactly, yeah.
So Ramonabant, when it was being used briefly, was for appetite control.
Right.
So is there any development going on with respect to either antagonists or agonists for eating disorders?
You know, that Ramonabant thing, every drug company just pulled out completely. There was a whole bunch of other CB1 orthosteric antagonists being developed by different companies, and all of them dropped it completely after the Ramonabant debacle. So it would make sense, but it is intriguing that the things that it affected, it decreased cigarette smoking, Ramonabant purportedly decreased triglyceride levels and abdominal fat. So it had great promise, but with this mood stuff too, it was going to be a hard thing to develop. So I think a negative allosteric modulator, or something that could be more subtle, would be a better approach than just blocking endocannabinoids completely.
What about THC agonists for anorexia?
I know. I think somebody might be doing that. It's a really interesting idea. It certainly works in our lab on increasing food intake. Yeah.
David?
A couple questions. The Juul delivery device, do you think that the administration is like deeper into the lungs, or is it different in some way? Also, you haven't mentioned psychosis at all.
Yeah.
Which we
That's a whole other grand
round. In the suburbs,
Yeah.
they all the psychotic kids come in with heavy use, it seems.
Right. So with the Juul, I know just the same that all of anybody else who reads the New York Times knows, that it seems to be the solvents they're blaming on at least much of the lung issue. I'm not sure about the depth of inhalation, because cannabis is certainly, people inhale that deeply. So that still remains to be determined. You're talking about the lung consequences, I assume, right?
Also the effect on is it a deeper and more addicting
It is. My understanding is that they've changed the nicotine molecule slightly in the Juul that makes it even more reinforcing, rewarding. So, I mean, they're nefarious, those cigarette companies. Oh, no, the vaping, yeah, the vape and smoked are pretty close. Ryan Vandry did publish recently showing that vape does give a slightly different intoxication, but I'm not sure if it's a function of how you inhale it. Still, a lot needs to be done with that. So psychosis I haven't talked about because, again, that takes a whole other word. The one thing is certain, 100%, is that there is an association. So cannabis use is associated with psychosis. The debate in the field and the debate in our article was causality. There's a lot of explanations that could be explaining this association, but it's the causality that is debated. But the association is 100% increased risk.
I don't see any of our policy wonks here, but anybody's free to comment on this. But so it's hard to make a case that cannabis used recreationally is any more dangerous than tobacco or alcohol. So, one would say, okay, if people want to use it, they can use it, and you can say it's going to only be used by adults. But yeah, that's not going to really limit it, and it hasn't limited tobacco or alcohol either. So it's basically caveat emptor. So the idea of it being a recreational intoxicant, I don't know, maybe I'm a child of the 60s and I've already seen what the ravages are. But it's not so troubling. What's troubling is this, alleged medicinal uses that are completely BS. And, the fact that it's being touted as this panacea for all these things, and at best having some kind of euphoric or intoxicating effect is able to mitigate or mask, dysphoria or discomfort or something of that sort, when it's really not. We see a similar thing that's happening in a much less, significant way with the touting of MDMA for PTSD. So it's an empathogen psychedelic and is being proposed as a FDA approvable treatment for PTSD. And I find pharmacologically it being implausible. Now, the way they're justifying it is the advocates who are sponsoring the studies is that it's not the pharmacologic effect that's therapeutic, is that it takes individuals who are experiencing PTSD and it puts them into a subjective state where they can participate effectively in exposure therapy or whatever the desensitization treatment is. So you could say it's like anesthetic for surgery, I suppose. But I think that this is the risk, is that stuff's being passed along as being therapeutic with some flimsy approximation of data when it's really not.
And marijuana led the path for that, honestly now. I think Denver just legalize psilocybin for some indication too. It just led the path to people voting in a medicine in that sense. So,
That's what you started out saying.
Yeah. And so that precedent has been established, and I think we're going to see a lot more of that. And there's just again, it's just a deep distrust of science, I think, that's why so much has driven my annoyance and ultimately my research, because it's a distrust of science. So, imagine if Pfizer came out and said, we don't know how it works or what dose you need, but just take this, it's going to help you. Imagine. But your local Whole Foods doing that with CBD is fine, and because it's not the experts, it's not, you're much more comfortable buying it at a farmer's market than you would be from the drug, even when there's FDA, approval. So it's all coming from this deep distrust of science, I think.
No, I completely agree. So, interestingly, the current she was appointed about a year ago, COO of the medical school is a woman named Donna Lynn. You know who Donna Lynn is? So she was lieutenant governor in Colorado to Hickenlooper when he was governor. And it was while she was lieutenant governor that they passed their marijuana laws. And she basically said, we had no choice. It was like a tsunami of public opinion, and we knew it was, hugely risky and, undocumented and understudied, but there's nothing you can do.
Right.
So, it's really is worrisome. And I think you're exactly right. So for the younger people, particularly in the room, the challenge you face isn't just finding out the evidentiary basis of disease and treatment. It's the fact that as it's implemented and used for the educational purposes and the population, it's fighting against a gradient, which you're saying mistrust of science. The way I've sort of euphemized it is that there's a wish for magical thinking.
Yeah.
And it makes it more difficult. I mean, I don't think it changes, it deters us in any way. It's just that it may alter the kinds of creative strategies that we need to develop to make it more accessible or embraceable by people.
Right, and you look at CBD again, what it is purported to help with. So it's anxiety, sleep, and like minor aches and pains. Well, what 3 indications have a higher placebo effect than those sorts of things, particularly when you're being really encouraged to believe that it is? And, it was here in another grand rounds, I think it was to our wager, showed that placebo does shut down all the pain signaling pathway throughout the brain. Placebos work, physiologically when people really believe them. So again, it's not, there's a reason why that these are the 3 indications that people are using CBD for.
Well, I think that there's one other thing that may be relevant with regard to cannabis and THC and its mechanism of action. So I think apart from, like one big neuroscience breakthrough was when, going back to historically, there were, sort of several milestone things, but neurotransmitters were discovered, and first there was just a couple, then they proliferated, and there's many. But, the predominant neurotransmitters are the biogenic or indolamines and the inotropic receptors. But then there's a whole generation or a whole class of modulatory receptors, which the cannabinoid receptors are.
Yeah.
And there's an antipsychotic that's currently in a phase 3 study that actually we're one of the sites for, which is a trace amine receptor agonist, which is distributed, it's located presynaptically, and it has no effects on chemical neurotransmission administered by itself, but if you use it to sort of block the effects of other things, whether it's stimulants or whether it's ketamine or NMDA antagonists, it's able to block or mitigate those effects. So THC seems like it has sort of a similar type of mode of action. At any rate, I think we're almost out of time. Anybody want to ask one last thing? If not, let me just say, shout out to Fran and her division. We're really so lucky to have such a extensive, productive, and really scientifically accomplished substance abuse division. And keep up the good work.
Thank you.
That's great. Really,
Thanks so much. That was fun.